and welcome to everybody. Good morning, good afternoon. I think we've got people who span the entire globe here, depending on where you're joining us from. So I'm Elizabeth Ashbourne. I'm PQMD's Executive Director. And on behalf of our entire team, I want to welcome you warmly to the PQMD Pillar Talk, Displaced Futures, Health at the Crossroads of Conflict, Climate, and Cuts. This part of our ongoing Pillar Talk series where we convene diverse...
We, being a combination of Paul Masick as the practice lead, Brian, and myself, wanted to introduce to you a process that we're going to start.
Just a reminder, if everybody could mute themselves, we would appreciate that.
That would be great. Thank you. This session, I'll just recap here. This session is our ongoing Pillar Talk series where we convene diverse voices to examine leading insights, tough challenges, creative solutions across global health and humanitarian response. For those of you who are new to PQMD, and I do see some new, we are a global alliance of international NGOs and healthcare companies working to ensure sustainable access to quality healthcare, medicines, medical devices, and especially for those facing humanitarian crisis and living in underserved communities. Founded in 1999, we work on 6 different pillars: humanitarian assistance, health system strengthening, disaster response and preparedness, our guidelines, knowledge and innovation, and climate and health. And you'll find links to more information in the chat for all of that. I also want to say that this is the first Pillar Talk that is within the time of our 25th anniversary. So we're celebrating our 25th anniversary this year. And we're really excited to have many people who have been here all 20 years, of course, many, many new faces. So before we dive in, I just have a few quick housekeeping notes. As Victoria said, please enter your name and organization in the chat so we know who is with us. Riley, keep yourself muted unless invited to speak, but feel free to share questions or comments in the chat throughout the session. And the chat will be monitored throughout the session. So we'll be contributing your thoughts and information during the chat. And today's session is being recorded and will be available later this week on PQMD's Community of Practice. So today's conversation. As global displacement hits record highs, the world faces overlapping crises, from shrinking health, conflict, and climate-driven migration. Health systems are under immense strain, and displaced communities, especially youth, are bearing the brunt. Today's speakers bring deep expertise and lived experience to examine what's at stake and what's urgently needed for us to meet this moment. Moderating today's conversation is Dr. Dennis Cherian, Managing Director and Global Practice Head for Health and Nutrition at Chorus International. Dr. Cherian brings nearly 3 decades of leadership experience across Asia and Africa. He has driven health innovations in the world's most complex environments and currently serves on the board of the Ecumenical Pharmaceutical Network, where he chairs its Advocacy Advisory Committee. His background in health systems management, psychological counseling, and leadership psychology make him an exceptional guide for. Thank you again for joining us. And with that, I'll hand it over to Dennis to kick us off. Thank you, Dennis.
Thank you so much, Elizabeth, and welcome and greetings to everybody, wherever you are based. I look forward to this conversation today. For our June talk, Displaced Futures, Health at the Crossroads of Conflict, Climate, and Cuts. I look forward to a wonderful conversation with our panelists. At the end of 2024, an estimated 123.2 million people worldwide were forcefully displaced due to conflicts, violence, human rights violations, etc. To put this in perspective, this equates to 1 in every 67 people. This is according to UNHCR. Obviously, the trends have only aggravated in 2025, with more people displaced. I think the last estimate I saw was roughly around 300 million population. While the most displaced are as a result of conflicts, the impacts of climate and disasters on populations are also increasing, especially in the fragile and conflict affected settings. They are the most vulnerable to climate and other natural disasters. And most importantly, all of these countries are disproportionately affected with limited resources and their ability to cope and mitigate the impacts of climate and disasters. Often we find that those who are displaced are most impacted as a result of climate. In fact, they have multiple impacts, conflict, but also due to climate impacts. Take, for example, the Rohingya population in Bangladesh, which is one of the most impacted countries due to climate effects, like flood, for example. But it's also equally important to acknowledge the impacts of climate and conflict on the healthcare facilities and healthcare workers and their ability to operate safely. There are new and interesting innovations, whether it is climate smart agriculture or drought resistant crops, self-care or climate health products. For example, United works on very interesting health products that are adaptable to the context that we live in. For example, carbetocin is an alternative to oxytocin, which requires refrigeration, which is a drug that is most widely used to prevent postpartum hemorrhage. Or, for example, heat stable treatments, which can withstand the extreme impacts of heat. These are all very interesting, evolving examples, and the power of the human mind to think outside and to make solutions that are responsive to the evolving context that we live in. For our conversation today, we will explore the impacts of all of these crises, conflict, climate, and the impacts of funding reductions on our work. But also we will explore the impact on young people.
Update on the all staff about how we've spoken to all the speakers.
We'll explore the impact on young people. Young people, as we know, make up roughly 50% of the world's population. So what does this mean on the lives of young people? We also see that the world's ability to respond to this crisis is faltering. With cuts to funding, organizations are required to think very differently. But all is not lost. Individuals and organizations are pivoting. Organizations and individuals are finding new ways to address the important work that we are doing. We have an excellent panel here, those who have lived experience, but all those who are also professionals in this field and have spent decades trying to respond to the crisis that we are now facing. Let's hear from our panelists, their stories, lived experience, and the wealth of the experience that they bring working in this various context. We will have about 40 minutes and then roughly 10 minutes for Q&A. Our panelist today includes Jin Dawood, who is a Syrian refugee and an award-winning social entrepreneur. We also have Dr. Asad Kadum, who is a senior public health officer with UNHCR. And we also have Dr. Nesvin Teklu, who is the head of the health unit for IRC. I will ask each of the panelists to introduce themselves, stating their name, their role, and a brief insight into what brought you to do this important work. Let me start with Jin. Over to you, Jin.
Thank you so much, first of all, for organizing this and for having me today. For me, It's a long story. There is a lot of things happened, but displacement stole my home, but it gave me a mission, I can say. I was just a teenager when I watched my city and watched Syria turn into war zone. We survived airstrikes, ISIS occupation, and barrel bombs that shattered our apartment. So we decided to cross the border to Turkey. It was a journey over landmines and fear, but the hardest part came after the silence. The trauma, the feeling of being invisible. No one asked how we felt and how was it, what happened, and what we are experiencing now. The silence inspired me to create Peace Therapist because I realized healing is the first step to rebuilding not just lives but also futures. I will be explaining more about Peace Therapist in the next questions if we had the opportunity.
Wonderful. Thank you, Jen. Dr. Assad, if I may ask you to speak.
Thank you very much, Dennis. Good afternoon, colleagues. Good morning for those in the US and different time zones. So my name is Assad. I'm the senior public health officer working for UNHCR headquarters here in Geneva with the public health section. I actually joined the headquarters recently, 3 months ago. Before that, I used to work in UNHCR Regional Bureau for the East and Horn of Africa and the Great Lakes region. I was based in Nairobi for almost 4 years, and we covered our 11 countries. Like it's basically those countries in the Horn and East of Africa that is like characterized by quite big displacement emergencies, like either due to conflict or even in the case of Horn of Africa, we have also the drought situation and the climate change. So it was like multiple, like let's say, displaced factor that led to those emergencies. And like I find the work with UNHCR quite interesting and useful to touch up on a refugee health topic, because I'm a medical doctor by background and like specialized in public health. Before UNHCR, I was also working with MSF and IRC for almost 10 to 15 years, where I was also working in the field of emergencies. I remember, like now, Jen mentioned the Syrian crisis. I worked with the Syrian crisis from a 3 different angles with MSF, IRC, and UNHCR. It extended quite long, and in fact, just recently we started to see some sort of recovery in the situation where the situation changed. But it's a good example on how long those emergencies can last. Like it's over 10 years, and in fact our average of like displacements emergencies, it spans sometimes 15, 20 or even more years. So I find it quite interesting to work with refugees in general, but more specifically with refugees' health, and for me it's a topic that is passion for me, and I really enjoy it, and happy to be here and also to answer any questions and to engage in the discussions that will be raised by other panelist colleagues. So thank you, and happy to be here again.
Thank you, Dr. So over to you, Dr. Mesfin. We both have worked together quite a long time, and wonderful to see you again.
Yeah, thanks, Dennis. Hi, everyone. My name is Mesfin Taklutasema. I'm the head of health at the International Rescue Committee, based here in New York. For me, this is personal as well as professional. And, growing up in Ethiopia, where my country has seen a fair share of displacement, and my parent quite at early age in my childhood hosting internally displaced people from northern part of Ethiopia who was displaced by food insecurity and hunger. So I had quite enriching experience, living and hosting with them and sharing the resource that we had. And this is a story that I know many people who are displaced also live within their country, hosted by their neighbors. So I look forward to discussing more about this. And of course, at IRC, this is what we do every day. And Dennis outlined 122 million people who are displaced today in various forms. And our work is quite, focused in terms of helping survive as well as recover and from this crisis so that they can find a lasting solution for their displacement. So looking forward to the discussion. Thank you very much.
Thank you, Mesfin. Thank you so much to everybody. I put a link there. Yeah, you should take a look. It's very informative, excellent, I thought, that shows countries against conflict and climate, thanks to UNHCR. So let me start with Jin. Thank you, Jin, for your brief introduction. But could you speak a little bit about your journey, what it meant to be displaced as a young Syrian refugee, and what experience was it like for you and your family?
Yes, for sure. Like for us, and I think for every refugee, displacement is not a single crisis. It is a sequence of losses. We needed a lot of things: shelter, education, learning a new language. But what we needed the most was emotional safety. And according to the statistical informations, the 3 out of 4 refugees needs psychological support. But in my opinion, that 4th person also needs psychological support because of like the horrible experience could a refugee experience after the displacement and after like going to a new country. And when services didn't include mental health, especially for refugees, especially when I experienced myself the trauma and the horrible psychological effects of what I have saw and experienced after the war. And I could have seen a lot of refugees are still suffering from these psychological problems. And later, when I started to research on this, I was still a computer engineer 2nd class when I had the idea of peace therapist. I found out not only refugees, every human at a period of their lifetime, we could need psychological support, and that is our bare minimum right. So I wanted to make that solution. I wanted to take action, and I started to build peace therapist application and website as a computer engineering student. And it was officially based when I still a student, when I was a 4th class, where we wanted to offer culturally relevant and trauma-informed therapy in the mother language of the person. Now we are providing therapy in English, Arabic, Turkish, and Kurdish languages. And in the future, we plan to add even more languages to work with people all around the world, because we believe psychological support and mental health should be accessible, should be inclusive, and should be reachable whenever you are and wherever you want to reach out to it, because that was especially what I needed and what I can see from the people around of us who need psychological support to be more reachable. Throughout Peace Therapist, I'm proud to say now we were able to reach 70,000 people until today. And I'm being really proud of the feedbacks that we are receiving from the people about their therapy sessions they receive throughout Peace Therapist, because we are providing individual therapy sessions beside also of group therapy sessions and awareness sessions that is happening every week for free, all of them. So it making me even forget about the struggle I experienced after the war and about the struggle also building Peace Therapist, because it's another story of of being consistent and being insistent on the goal. Because the moment I had the idea, it was okay, I know what I want to do in my life after now, and it was like the goal and my mission. That's why like working on it 24 hours a day can be not only a job, it can be also a lifestyle for me. peace therapist is working in 3 different ways to make it clear. We work with individuals. We have more than 150 psychologists pool in our platform. Individuals can reach to our platform and can be matched throughout our AI system with the best psychologists according to their needs. They are matched according to the experience of the person and the expertise of the psychologist, language, the preferences of the gender. Also,
let's come back to you again. You can explain in my additional questions. But let me ask Dr. Assad. Obviously, this work requires a lot of coordination that includes working with government, communities, multilaterals. How are these actors working together, and what do you think needs to change or shift to make our collaboration more effective?
Thank you very much, Dennis. So when it comes into coordination, I cannot emphasize how important and a crucial role it plays. Like, in fact, good coordination will dictate if like an effective and successful response. Like without it, we cannot really achieve appropriate response. So during refugee emergencies or displacement crisis, we have number of coordination platforms usually made available depending on the type of emergency. Like if it's refugee, IDPs, or mixed situation. Within UNHCR, we have different type of situation. For instance, if it's refugees, we do have a mandate when it comes into the refugee health. But if it's IDP situation, they are considered citizens. So we have, like, let's say, lead role in other sector, but not necessarily health. We still have interaction in health, but not necessarily leadership role. Obviously, governments plays a vital and leadership role in the process. So usually UNHCR works closely with the host country governments and the different departments to facilitate the response. So in some countries, they have created a specialized departments for refugee response. Like in Ethiopia, we have the Refugee and Returnees Services, or RRS. In Kenya, we have DRS, Department of Refugee Services. In Jordan, we have the Syrian Refugee Affairs Directorate, or what we call it SRAD. So those bodies, because those countries have been exposed to multiple refugee emergencies, they created a specialized body that we usually work with them and make sure that they are available and coordinated at the outset of the emergency. When it comes into health specifically, obviously MOH or the Ministry of Health is the main government partner that we work with, and we work closely with them on many aspects, like especially when it comes into surveillance, outbreak response at the outset of the emergency, so at the beginning. And then later on, we also work with them on inclusion and on inclusion in the national health system later on. And I will also explain why inclusion is important when it comes into as an approach, why refugee inclusion in the national health system is quite vital. In refugee camps or refugee settlements, we have refugee coordination models. It's usually implemented during emergencies, and UNHCR co-lead the health sector, usually with Ministry of Health or WHO or someone else, while a cluster coordination model applies in IDP or mixed settings. To assess the needs, a joint need assessment usually conducted with key stakeholders and partners involved to ensure that there is a coordinated and coherent response are in place. Coordination of health sector is similar to any other humanitarian coordination. So obviously it seeks to improve the effectiveness of the humanitarian response by ensuring predictability, accountability, and partnerships. We try to avoid duplication of services, and the primary purpose of coordination is to achieve maximum impact with the existing resources. Talking about resources now, like with all of the cuts, it makes the role of proper coordination is quite key. So basically we aim to achieve more with what is available, and without coordination, efforts of the health agencies are often inefficient and duplicated services in one areas, while we have like gaps or uncovered needs in other areas. We aim also to generate some coordination of products, like for instance, dashboards, reports, policy papers, 3, 4, 5 W's, so who's doing what, where, and when. This would help all of the partners basically to coordinate their planned activities together. And also we have a health sector humanitarian strategy. So make sure that everyone is basically signed in, and in many occasions it's developed with partners to make sure that they are all aware of what's happening, and we include all of the key stakeholders, if it's Ministry of Health, if it's the NGO community, international or local, and even the donors in some occasions, because like donors play like more increasing role in that. Regional response plans and financial trackings are also another like tools that is used in coordination. So this is basically in a nutshell what we do when it comes into coordination, and why coordination is quite vital in ensuring coherent and effective response. Over.
Thank you so much, Dr. Assad. Dr. Haswin, anything to add as an ING, and how do you think in your work in IRC, any alternatives?
Yeah, thanks, Dennis. And Dr. Assad has already elaborated the type of coordination that we do. IRC is part of the humanitarian system, and both as an operational agency and also as a convener in the area where we have the comparative advantage. So the way I understand coordination in this kind of situation is that ensure every actor in this ecosystem is doing their part well. I think, whether that is international NGO, UN agencies, or local community or local actors. I think I want to give an example that IRC actually has worked on. What we call it, REACH project, which is, immunization program to reach 0-dose and missed communities in fragile humanitarian settings. So we have been, implementing this program across 6 countries. That's Ethiopia, Sudan, South Sudan, Somalia, now expanding to Chad and Nigeria. And these countries share a common border and also serving people who are displaced by conflict and disaster. So just to give you a context, that in 2023, 21 million children did not receive a single dose of vaccine, or not the full course of vaccine, what we call them 0-dose children or missed communities. So, this 21 million sounds like, insurmountable challenge. But the way we have done is we bring together a coalition of partners, each partner having a comparative advantage in terms of their capability to reach these children. And that includes, IRC as a convener and as well as implementing partner, and including local actors who have the local know-how and the knowledge of the area we operate, and also the local health system, Ministry of Health, with some of the health facilities that are run. And I think the unique part is that it's not just only humanitarian. Immunization is also, a health system work, and in a way that is a combination of the humanitarian approach plus the immunization principle, that we are able to reach communities that have been left out of the immunization program. When we started the program, only 16% of the communities, which is around 150 districts, were accessible. As of recently, 96% of these communities are accessible. This is because, some of the areas are controlled, by armed groups, and, through painstaking, negotiating access and reaching, bundling immunization with a humanitarian approach, we are able to reach these communities. So, and of course, immunization, as you know, it requires also trust and accepted by the community. And some of our partners are also from the local, who have the acceptance by the community. So to me, coordination is about, bringing the best of everybody for achieving a common goal. And I think that's how we did it, in this kind of settings. So it's not just, in places where it is easy to deliver service, but in fragile and humanitarian settings, it's possible to help people who are affected by double burden of, conflict, displacement, and climate change. And I think we need to make sure that, we look at coordination as a means to achieving a goal, not just only coordination for the sake of coordination. Thank you.
Very good. Thank you so much for that excellent example, and also trust as an integral part of collaboration as well. Dr. Assad, obviously UNHCR plays an important role in emergency and also long-term systems building. Are you able to share a little bit about how UNHCR works to strengthen the national health systems and to ease the burden of the health systems? And how do you balance support for across displaced populations, but also host countries as well?
Certainly, Dennis. Thank you for this question also, which is quite useful and very important. So when it comes into like during emergencies, what we aim to do, we try to work closely with the Ministry of Health and the local authorities. So as I mentioned before, we have like the local authorities and the government, different departments are our key partners that we want to engage from the beginning, even in the emergency response. So we had recently for UNHCR also, there has been a sort of change in policy and our strategy to work more with the terminology, what we call it inclusion from the start. So, and also the sustainable responses. So with multiple protracted emergencies, like Dr. Mesfin and you mentioned, last year we hit 122 million. We crossed this like basically margin of the number of the refugees and displaced population. So and not to mention also protracted emergencies and record numbers of the displaced population globally, it is no longer sustainable to deliver healthcare through vertical systems or programs. Like hence the approach, it's to include refugees in the local health system from the outset of the emergency, like from the beginning, and to invest more in doing capacity building on the local health services to enable them cope with the increased number of population. Because most of the majority of the refugee population, when it comes into their locations, are usually in rural areas and close to the borderlines, where the national health systems are not necessarily like very well capacitated. So to ensure that this arrangement or this approach would work, we really need to make a big investments on the capacity building of the local health system in order to like enable it to absorb the additional number of the population coming to those areas and to avoid any potential system collapse. Health system strengthening is essential to enhance their capacity in terms of quality, ensuring that they can also adequately serve both refugees and the host communities. And solution inclusion from the start, including early engagements of the development actor, is also paramount to avoid the creation of parallel systems or legacy programs that basically will not be sustainable over like the long run or even to foster dependency. For emergency preparedness phase, key principle is emphasized, including alternative to camps. So like this whole concepts of camps, we are trying to avoid having the concepts of creating of camps as much as possible and avoiding the creation of parallel services and encouraging, like for instance, cash assistance for refugees and other programs that enhance their inclusion from the beginning. Also support to local and national authorities to provide basic services from the outset through like area-based modalities. Like I remember in the Eastern Horn of Africa, an Ethiopia operation implemented this successfully during the emergency response for the Dulu zone of Somalia regions, where Regional Health Bureau implemented the delivery of health services for the new influx of refugees. That was the first time we basically implemented it really well and successfully, because it required like a proper coordination like from the beginning with them, and it's a time-consuming process. It doesn't work like or assumes to work from the beginning. It requires like long-term investments, work on the needs, make sure that all of the key stakeholders are engaged, if it's like development actors, if it's the local governments and other key stakeholders within the health sector. So this is the way we try to set it up, and this is now, out of all of the time, it's key again because of the whole issues with the current situation of funding cuts. And in fact, we are trying to to mitigate the funding cuts in a way that would make it more work, like you said, making more with less, and also try to take it as an opportunity to, like, let's say, reform the way we are doing work and to avoid having like paralysis in I would say in some places where we deliver services. Like, just to give you an example, when it comes into the cut, and this year we have 47 countries, like this is 90% of our country operations made budgetary cuts for health programs. So this is in the amount of $81.9 million. It's a quite massive amount when it comes into the way we implement health programs. Like it's an almost 41% of our global public health budgets. And out of those, 22 countries have reduced their budget by more than 50%. So this is, again, in terms of a scale at country level, it's a quite large. And then also 1/3 of those countries like face significant barriers or restrictive policies when it comes into health inclusion, and they're projected to require, like according to our estimates, 3 to 5 years for fully transition toward inclusions. So it's quite important that we emphasize and work on inclusive policy in the transitions toward working with ministries of health and sustainable responses to deliver even an emergency response, like not only for protracted emergencies, but also to like work on the concept of inclusion from the start and working with the local health authorities to deliver necessary healthcare. Over.
Very good. Thank you so much. Jin, you have an inspiring story. Can you talk about, sorry, this automatic light, it just shuts off. We often talk about services in isolation, but displacement is a long, complex story. From your own experience, can you talk about what are the services you received and how they helped you in your journey? If you can be brief, that'll be helpful. Thank you.
For sure. In fact, in my journey, it was like pretty long journey where it was not like an opportunity to receive therapy or psychological support. It was the education system was a bit confusing at the first time we came to Turkey because like of the system changing. So we couldn't have the opportunity to receive like or beneficiate from different services, for example, I can say, but I can tell that the ideas of change come from the needs and come from the gaps. That's why at Peace Therapist, I wanted to build Peace Therapist where like it was the first and most necessary gap that needed to be filled, because as a refugee or any person who need to rebuild themselves from zero, that we need to be strong enough inside to be able to build our new lives from zero and to be able to be resilient to be able to support our close family and friends. That's why it's so important like to work on this and to have different kind of support, for example, like supporting and doing partnerships with refugee-led organizations can lead to a really amazing solutions. I can give examples from the ones we have did, for example, with UNHCR, where we are now actively working with refugees and with women refugees in Turkey and in Syria also, and also working on social cohesion between host communities and refugees in the country. With ILO, we collaborated where we were able to take action immediately after the big earthquake hit Turkey and Syria, for example, and many different other global and local collaborations that was even possible. That's why the more powerful we are, the more powerful our social plan also can be, because we are also providing free mental health services for refugees. That's where like Peace Therapist idea come from, building inner peace and also contributing in building peace in the world. So because we believe and know that dignity and healing are not luxuries, they are rights. Thank you.
Thank you, Jin. Hasbin, I know that IRC obviously had to undergo a lot of organizational changes in light of the operational decisions that impacted staffing, programs, and also restructuring. Can you speak a little bit about how are these decisions impacting your work on the ground, and are you able to quantify in terms of how many people are displaced and cost of funding, etc., if possible? Thank you.
Yeah, thanks, Dennis. Yeah, obviously, we have faced significant funding cuts, mainly from the US funding cuts, as well as other European donors as well, actually, who are cutting back their spending for overseas development assistance. It's also worth putting that in context, even in 2024. The joint UN appeal faced a 25 billion funding gap, and at the same time we're nearly 300 million people in need of humanitarian assistance. So this cut came on top of already existing chronic funding deficit, and of course the funding cut has made things even more worse. And IRC, like every other organization, we have faced this funding challenge. And however, we have also been able to adapt and be able to navigate this funding challenge in a way that maximizing our investment and focusing in the area where aid can make a big difference. So that has been the focus for IRC. And of course, there are quite many analyses that have been done, but our analysis showed that the need and extreme poverty are increasingly concentrated in fragile and conflict-affected settings, and these are the areas who are also facing the impact of the aid cut. So they are facing actually triple burden from crisis as well as funding cuts. So. And at the same time, I think currently our aid is aid is thinly spread across multiple priorities, and undermining, of course, spending on what aid does best, which is basically delivering life-saving service in the most needy area, which is the fragile humanitarian settings. So to maintain progress with limited resource, we have to adapt and also deliver aid to the places that this will make a difference. So we have, recently published a report, A New Era of Aid. If you haven't seen it, I think some of my colleagues who are in this call can put the link in the chat. I really encourage you to look at that report. It's really laying out a roadmap for some steps to address a new era, which we are currently now. Aid cuts together with multiple traits of vulnerability. And I think some of the recommendation I'll just highlight. One is we must prioritize geographies or location to reach the most at-risk communities. So it's not everywhere that the need is the same. I think we need to prioritize the area where aid make a difference, which is places where affected by conflict and humanitarian settings, and also focus on programmatic intervention and solutions that are proven to deliver maximum impact in crisis settings. Dennis, you mentioned earlier, heat-stable oxytocin, which is important for delivering, stopping postpartum hemorrhage. We are actually leading a global consortium to address this using, delivering this high-impact intervention in humanitarian settings. So, in addition, like, immunization, I mentioned, 0-dose and under-immunized children, they live in fragile humanitarian contexts. Delivering aid for these children, controlling vaccine-preventable disease is important for the children who are receiving the vaccine. It's also important for the global community as a whole. Preventing disease outbreak anywhere is a public good. It reduces, the spread of outbreak and as well as global health security risk. And the other is also we need to ensure a model of aid that reach, the most in need, and as well as, supporting local humanitarian actors. I think the partnership I mentioned earlier, it was a combination of international and local organization. And the local organization, who lives through the aid through the context, have the know-how, who can be able to reach communities. So we need to support them. And of course, lastly, we also need to innovate in terms of financing. It's not just only more aid, it's also, smart financing. There are innovative financing like debt swap, that IRC using in some place like Kenya, where, a combination of debt buy down by, investment bank combined with the private sector, investment, and including the role of pharmaceuticals, who can also actually complement this package of services, really to make finance more available and more smarter to deliver aid in these settings. So there are multiple instruments out there. We need to leverage that. Probably we have not used them traditionally, and use those grant-based aid where debt swap may not be working, in the in some places where this instrument may not be appropriate. So IRC is actually navigating the current funding crisis using, adapting our delivery model and maximizing or focusing in the area where aid can make a difference, and also working with a range of partners really to bring, smart finance to the humanitarian system so that we can serve more people with less resource, which we are currently facing now. Thank you.
Thank you so much, Masvin. Very interesting, creative ways of trying to continue to do good. If I may switch, you already alluded to innovative financing as well. But focusing on young people, as I alluded to in my introduction, roughly 50% of the world's population are young, and young are the most affected. Aswin, how do we risk, what do we risk if we fail to invest in them? And especially adolescent girls and the impact of displacement on the health and well-being of young girls and women. And what services should be prioritized, and how can youth be an integral part of this kind of programming?
Yeah, youth and other adolescents, they account a largest proportion of displaced population, and they are also the future. And so, any program that doesn't recognize and include them would be basically not fit for purpose, I must say. So we must have a tool to be able to reach them. And that's, at IRC, we have a multi-sectoral approach, which we look at education as a key vehicle for protecting children and as well as adolescents and youth from violence, and also securing their future. So putting girls in a school, prevent them from, being exposed to abuse and violation. It also build their security and future for their future. In many of the settings that we work, the average displacement is more than 20 years. That is a place where children are born, growing up through their young age, and even to their adulthood. So we can't just approach the situation with just short-term humanitarian intervention. We need to look at a long-term investment that would build their agency and also create opportunities for them to be able to survive as well as thrive. And that would create a cohesive and inclusive society. As I mentioned in my own story, that many displaced people are hosted by communities who have also very limited resource. And supporting, the local community together with the refugees or the displaced population would enable, cohesion, and as well as promote, integration, which is, again, one of the solutions that we promote in terms of, long-term solution for some. So I think, the other service, when it comes to health, access to sexual reproductive health for girls and boys as well. And ensuring that, they have access to adequate nutrition, and there is a protective environment, because even boys and girls are at risk of recruitment for armed groups. So I think, a range of protective programming that we do in these settings would enable or preserve their health and well-being. It's also create opportunities for their future development, because at the end of the day, many of the people that we know, if you look at many of the soccer players in Europe, many of them are refugees. And if they have not given the opportunity to grow and thrive, they will not be a member of society that would give back to their community. So helping refugees is actually helping ourselves as well. It makes us more stronger, not less. Thank you.
Very well said, Mesfin. In the interest of time, I need to ask a question to Dr. Khadoum as well. And if we have time, we'll come back again. There's a topic we didn't talk much, which is about climate change. And as I already alluded to, how it's impacting and amplifying displacement, altering health risks, especially in displaced settings. What are you seeing on the ground, and how does climate adaptation really look like in these kinds of crisis affected contexts? And if you can speak also about its impact on women and girls as well, and how are programs adapting to address these critical needs?
Thank you very much, Dennis. I will try to be brief so we could allow some questions also from the participants. So when it comes to climate, obviously it's one of also the push factors, especially from the region I came from recently. Like I remember in the Horn of Africa and the Great Lakes in Somalia and in many other places, we have new waves of displacements, like pushed primarily because of like a climate change, like let's say aspects, like for instance a drought, multiple droughts and failed rainy seasons in Somalia created like a quite high proportion of food insecurity, malnutrition that pushed people or population elsewhere. The same thing in South Sudan with the flooding and many other places. Like in the last 10 years, we are experiencing more and more extreme like weather conditions and phenomena like linked to the climate change, which basically push the population forward. When it comes into health, like a climate change can have both direct and indirect impact on refugees' health. So direct, obviously, it include like normal heat-related illnesses, malnutrition, and in severe cases, even injury or death. And then a drought and the flooding may cause both like water and vector-borne diseases, outbreaks, as well as damage and the closure of health facilities. Like I remember just last year, we have like the Kakuma refugee settlements, the health facility there were not accessible for almost 2 months, primarily because of the flooding. The same thing for the flooding that affected Burundi like 6 or 7 months ago, is the same situation where access is basically compromised. So this is when it comes into the number of examples like related to the restricted access related to the climate change. And then population displacements, we spoke about it, like for instance, related to overcrowded in location, hosting IDPs may also further increase the risk of outbreaks and infectious disease. Indirect effects arise from changes in the environment that foster spread of the disease. For instance, we have like higher temperature and altered rainfall patterns can create ideal breeding conditions for mosquitoes. And this increased the risk of malaria and dengue fever. We started actually to observe multiple malaria outbreaks in a number of locations. And in some places, like we started to find out that those are not necessarily previously endemic areas where we started to have more and more malaria cases. And obviously the evidence is not there, and like even the academia has started to try to work to publish evidence linking those to like disease outbreaks and other like health outcomes. These impacts are also magnified on refugee settings because the health systems are under-resourced and like many lacks capacity to respond in full range and severity of health-related like needs. So as a climate-related weather events become more frequent and intense, the vulnerability of displaced population is expected to grow. So that's why we have like a bigger concern when it comes into climate change in relation to refugees and refugees' health. Over.
Wonderful. Thank you so much. We are short of time, but in the interest, I mean, we have been listening to our great conversation. Let me open it up to our audience. And if they have questions, then please feel free to answer. Any questions to the audience? Don't feel shy. Let me ask, while others may open up, let me ask our panelists, what is one metric that you would want our audience here to track over the next, let's say, 12 months? And a concrete example you want to see us all measure over the next 12 months? Jin, Mesfin, Asad, each of you.
I can tell
Very brief.
one
Okay.
small one. So, watch as one metric to watch. I ask you to watch the rise or fall of mental health access in humanitarian response plans.
Mhm.
If they are not rising, we are failing the future.
Very good. Mesfin.
Yeah, in a situation where we are facing multiple threats, including aid cuts, we must be doing more, not less, because the people who depend on our service are more, and the number is not going down.
Uh-huh.
So our ability to continue to deliver aid at scale, and including proven intervention that we discussed today, and the number of people that we serve is the one that metrics I would use. So it is a time for doing more with less, but not less with more.
Very good. Well said. Dr. Asad.
I will also echo what colleagues mentioned. We are really in a time where we are obliged to do more with less. I mean, the whole climate of funding cuts globally, it has nothing to deal with the number of emergencies that we are seeing. Like, we are actually seeing more and more emergencies happening. Just now, the South Sudanese new emergencies and the new displacement, it cannot come in a worse time than now, like with all of the climate of funding cuts and so on. So crises, conflicts are continue to happen. We just saw now also in the Middle East and elsewhere around the world. And in addition to the climate change and like other like natural disasters and so on. So we are really obliged to think differently, to be more innovative, and to try to achieve more with less, and to try to focus on the interventions that basically will really make the difference for the refugee population and the displaced population in general. And in terms of like, let's say, when it comes into metrics, we are having a quite like concerns to try to measure certain indicators when it comes, for instance, for mortalities indicator, like all of the progress that we made in the last 20 or 30 years when it comes into reproductive health, infant mortalities, maternal mortalities, even crude mortalities and so on, is at risk at this time unless we manage to achieve like more successful ways, or like more differently how we plan things. Like just now in Sudan, the cholera outbreaks, we are seeing like a spike in mortality rates from a disease that is very much preventable. And for the time being, we are linking it to the lesser resource availability for those type of things. So unless we do the things differently, we are unfortunately going to see much more higher like deaths and preventable mortalities and deaths and so on. Over.
Very good, very good. I know we are at the top of the hour. I see 2 questions in the chat. Do we have time to answer those questions?
Yeah, I'd say briefly, Jin, the first one is for you if you wanted to answer it, and then the other 2 are for Dr. Kadam. I'll just read them quickly. Jin, sorry, more are popping up. Jin, your application, how many languages, and is it accessible in other regions?
Yes, for sure. Thank you for your question, Ushaba. Yes, our application is now available. It's in fact, now we are working on the platform. It's now available at the website. I will share it now on the chat section. We have a website where anyone can access psychological support online And we also do collaborate with organizations. We don't only work with individuals, we also work with organizations, and it's available in 4 languages now: English, Arabic, Turkish, and Kurdish languages. Until today, we were able to work with the beneficiaries and psychologists from 26 countries, and we work also to add new languages to reach even more countries in the future. I will be sharing our WhatsApp hotline also in the chat section beside of our website for make it easier for people to reach out to us if they're wondering if anyone is willing to reach out also.
Thanks, Jen. And the last question is, how are UNHCR and IRC investing in local actors for sustainability? In less than 30 seconds, if possible, for each of you.
Yeah, I can quickly say for IRC, as I mentioned in my example, localization is a commitment, organization commitment. Localization means supporting local actors and partners. And we have a tool actually well known in the sector. It's called PEERS, P-E-E-R-S. We can share the link with that. And how we actually work with our partners to enable them as a partner, not just only someone who received grant on a transaction relationship. So really, that's our commitment. And we have an organization commitment even to transfer at least 25% of our funding through local partners. So that is a level of commitment IRC has to localization. Thank you.
Dr. Assad?
So, like from our end, and try to squeeze it in 30 seconds. We are empowering and encouraging what we call it refugee-led initiatives. So basically, even for instance, in mental health, we try to work with them on scalable interventions and trying to deliver through those type of initiatives. Community health teams, for instance, in Uganda is the same. Although the challenge that we have when it comes into funding cuts, those are the interventions that many partners try to cut at the outset or at the first, but we try to re-put them in the front, having working also with local partners. It is now integrated more in our policy and strategy, but mainly the refugee-led initiatives is the one that we are trying more and more work with in different settings, especially in the Eastern Horn. I remember in Kenya or elsewhere where there are more good environment of sustainability and self-reliance. This is what we are trying to work on overall.
Wonderful. Thank you so much to our excellent panel. Over to you, Elizabeth, for the closing.
Thank you very much. Yeah, I mean, I suspect we could go on for at least another hour, if not a whole day. So thank you so much to our incredible speakers for making the time. Again, Doctors Mesfin, Assad, and Jin, for sharing your expertise and your insights and your experience with such honesty and clarity. And thank you also particularly to Dr. Dennis Cherian for skillfully guiding us through today's conversation. And I really look forward and hope that we'll continue it. In these times of diminishing resources, I also think your points about challenging priorities and focus of donors around displaced people, particularly youth, the impact of climate access to mental health services, and rethinking how we position, finance, and offer aid was really compelling. And I suspect that is an entire conference worth of topics that we could continue discussing. So to everyone who joined us, thank you for being part of this important dialogue. We encourage you to continue the conversation on PQMD's Community of Practice, where today's recording will be available shortly. So we look forward to seeing you at future Pillar Talks. And until then, take care and stay connected. Thanks so much.
Thank you so much.
Yep.
Thank you. Thank you, everybody.
Bye.
Bye-bye.
Thank you. Bye-bye.
Thanks so much, everyone.
Thanks,
Really great
everyone.
discussion.